Yeah, so Dr. Mary Lewis is a palliative care consultant here at Derby and Burton. She currently works across several aspects of the service, including being the lead for community palliative care, and she does a regular hospital palliative care clinic as well. She's got a particular interest in lymphedema and has developed the Derby lymphedema service here as well, so it's brilliant to have her on.
I've got about 40 minutes to talk to you about palliative care, and specifically with endometrial cancer. And so really my aims are to build confidence in professionals in supporting patients with endometrial cancer as they enter the end of life. So part of that is recognising when people are entering end of life, and part of it's about managing, but also what else can you do to help and who can support you as a healthcare professional. So the first step is recognising what we mean by the term end of life. So there was a definition in 2010 from the GMC, which talks about end of life being anywhere between the last year of life and last hours to days, which kind of can make it a bit of a vague term. But what we tend to find is clinically, we use the words end of life for very much like last hours, days, weeks, whereas more strategy based, we're often talking more last 12 months of life. But also the GMC definition reminds us that the incurable progressive cancer might not be the only condition that somebody's facing. They may also be managed with general frailty. There may be coexisting conditions, and we do have to remember the whole breadth of acute and chronic conditions when thinking about what end of life looks like for any individual patient. So there are many prognostic tools that have been developed for cancer patients, but research tells us that clinical intuition is as good as prognostic tools if we can be honest with ourselves. So one way of using your clinical intuition is to ask yourself what has become known as the surprise question. And that's, would I be surprised if the patient in front of me were to die in the next few months, or surprised if they died in the next few weeks or days? And then you need to trust your clinical intuition and maybe not be too harsh on yourself, because at the end of the day, we're not trying to give people a black and white, yes or no, you are going to die. It's starting to have that conversation about the fact you might be worried, the fact they might need to start wanting to prepare, and the fact that we need to start changing direction. So really what we're starting to do by trusting our clinical intuition is communicating uncertainty and communicating our worries about how the next few weeks or months might look. So what do we base our clinical intuition on? I guess these are all things that you will do naturally, but they're questions really beyond just thinking about the performance status. So you're looking beyond the performance status at other comorbidities, about the symptom burden, because obviously the symptom burden brings in some quite strong drugs, often some controlled drugs that may affect how much people are up and about. You bring into your clinical intuition what the response to treatments are looking like. So as you're getting decreasing reversibilities and poorer response, and you get a sense that things are getting worse. Markers like cachexia, weight loss, reduced eating, early satiety, recurrent infections, recurrent illnesses, those sort of grumbling problems that won't quite go away. Red flags are repeated unplanned admissions, crisis admissions. Sometimes there's a sentinel event, like a serious fall that maybe causes a broken bone, or a partner's bereavement, or the transfer to a nursing home, that often actually warns us that something significant is happening because it affects people's physiology. We know there's a much higher mortality after a patient's spouse dies. In the year after a spouse dies, people often have higher mortality. And from a blood perspective, we're often looking at serum albumin because it's a marker of inflammation and poor reserve rather than nutrition. So that can often be quite an interesting guide. So when you're thinking about prognosis, give you some general tips from a palliative care perspective, which is that no health professional will hold you to account with your prognostication, but the patient might. So that's why I would always say be careful to be as honest as possible. You can't be criticised for being honest, but do avoid using numbers, because it'll be the number that the patient remembers. So we tend to just talk in terms of hours if we think it's potentially very soon, days, short months. Sometimes I use the phrase seasons, and maybe even a short number of years for somebody who's really doing quite well. I try not to use the phrase end of life, because I think that has different implications, and I don't think it means very much to the general public. But also, I think as long as somebody's still having ongoing treatment, we have to be honest and say that there is a bit of a lottery in oncology treatment, even with all of this new knowledge about checkpoint inhibitors and what markers are being expressed by the tumour. The tumour is still changing sometimes, and so we don't know precisely which treatments are going to work. But we have to be clear that therefore our ability to predict prognosis for people on treatment is variable, but also we have to be really clear whether we think the patient's curative, because I think that's the very least we can offer them. If they know that we're trying to cure them, I think that's a good message out to the patient and the other health professionals what the general goal is. But if we don't think that they're curative, I think people need to know that we can tell them that with a sort of an idea about how long we think things will hold for. And I think it's always worth remembering that delivering bad news will cause distress. It's okay to cause distress. Our job is to deliver the bad news. Our job is to acknowledge that we've caused distress. And sometimes I use the phrase, is that a shock, rather than I'm sorry, because I'm sorry almost implies that I need to pull back from it or change direction. So I tend to say, is that a shock, and pause and get a sense of how much the patient was expecting the bad news. But if you never give the bad news, if you never give the distress, it's harder for the patient to keep adjusting their goals and expectations and coming to terms with that loss. So I would always say, deliver the bad news, but then just sit back and try and see how much you've affected that patient, how much they're expecting it. The other point is sometimes of just sitting back, giving yourself a pause and asking if it's a shock, is it gives you a moment to notice your own emotions. Because you could insert any number of emotions into that sentence of, instead of feeling helpless, people often feel they're fearful, they're frightened of causing distress. They don't have the time in clinic to deal with the distress. They may feel a pressure to get it right. They may feel a generalized panic that they're delivering all this bad news without actually having been able to have time to assimilate all the facts. So sometimes if people ask you about prognosis, sometimes just to be honest and say, I don't know, I haven't got all the information in front of me. But actually, maybe sometimes responding to the unspoken question, which is, if we know I'm not curative, what else can I do? What's your position in this? What can you do to help me as a health professional? What else? Who else can help me? Who else is there out there? So sometimes when people are asking about prognosis, you don't necessarily have to have answers if you haven't got time. But maybe that's your moment to start thinking about, do I need to do an onward referral to this person? Do I need to make sure the GP is aware? Do I need at least to be honest whether they're curative or not at this stage? So moving on towards sort of more specific about endometrial complications. The complications on this slide are not by themselves determiners of the last year of life, but it's a little bit like those sentinel events on the previous slide. The complications start to build a picture of disease progression and frailty and reduced reserve. And so often these are the events that we can stop and reflect with the patient about disease progression. And these are the events that enable us to introduce conversations about limitations of treatment and what's possible and what's not possible. So bouncing on from that slide, we'll just talk about how we can manage end-of-life scenarios. So you'll be familiar with the fact that the patients have a range of symptoms. I think these symptoms are quite broad and quite specific, quite open to most of the gynae cancers. A whole talk on pain is beyond the scope of the time we've got, but if I can just remind you of some of the really sound principles about assessing pain. So number one is take a good history and really listen and try and correlate the pain with the latest scan. And if there's more than one pain, just try and address each pain in turn. And if a pain doesn't correlate with the scan, that doesn't mean it isn't a pain. That just means we've got to try and work out what's causing it. The WHO ladder is still a really good starting point, but don't forget that opiates won't treat all pains. Neuropathic pain, spasm in the bowel, tenesmus, inflammatory pain, infection, subacute bowel obstruction, constipation all need to have slightly different tailored approaches, and often it's a case of trying to treat the underlying problem. If you suggest analgesia, it's really important to have some clear communication about who's going to review the analgesia and share those expectations with the patient and share them by letter. So if you're expecting the GP to follow up on it, I think it's quite important to get that in the letter and copy the letter to the patient, so the patient's got something in their hand they can take to the GP and say, my pain's still not controlled. Remember that our patients who are dying often need analgesia via other routes. So patches are useful for stable pain. Syringe drivers are useful for those people who can't swallow or people who are vomiting. Just sometimes thinking broadly is all we need to do. So vaginal bleeding, you'll be more familiar with managing this than me, but from my palliative care approach, don't ever forget the anticoagulants. We just have a lot of patients now on anticoagulants, especially the elderly. And I tend to have a really black and white risk versus benefit approach. I tend to say to people, if the bleeding is affecting their quality of life, let's deal with it in the here and now and start cutting back on the anticoagulants and give them a sense of if we're managing it for AF, they've got a quite small chance of having a stroke each year. Generally, I quote less than 5%, whereas they're actually bleeding now, and that's causing them distress. We're quite fond of tranexamic acid in palliative care for sort of localized fungating ulcerative disease. We can put it on topically. We use it orally. It can be used acutely at home, but it does take 2 hours to start to work once it's been swallowed. Intravenously, obviously in hospital, but we tend not to use that much in palliative care. But we can put an example. We can, sorry, somebody's talking. Right. We can put tranexamic acid in a syringe driver in the community. So we can use it for those people with ongoing bleeding who can no longer swallow or absorb. Bowel obstruction is also a talk in itself. I tend to find that these people tend to come to palliative care because once you've got a bit of low-level, intermittent, partial bowel obstruction, you'd need somebody really who's following you almost sort of week by week, because it gets complicated to manage. It's often due to tumour causing external compression, or there might be functional occlusion of the GI tract, or there might be tumour infiltration of the muscles or the nerves. But it's often a case of going along somebody side by side, changing their diet, going to the low residue, sometimes liquid diet, sometimes helping them think about resting the bowel for 48 hours when they're getting cramps, rather than putting up opioids and hyoscine, because once you put the opioids and hyoscine up, they often don't come back down again. And then the bowel gets a little bit slower and a little bit slower, and more likely to get constipated on top of a tendency to bowel obstruction. We try to keep people on stool softeners to keep everything soft and able to get through these partial blockages. We tend to give our patients short courses of subcut steroids, generally to see what 5 days of subcut steroids do and whether releasing the bowel a little bit helps. And I think the reason we often kind of work alongside the patient is because we're trying to work out what's the best thing to put in our drivers based on examination, history, symptoms. And so your choice of antiemetic all depends on whether you're getting a lot of colic or whether you're just getting a lot of nausea but no colic. So bowel obstruction is complex, and and generally we're quite happy to help and take over to a large degree. Fatigue, weakness is a huge symptom that goes across all cancers. Acknowledging it is a significant symptom, I think is important. There's not an awful lot we can do as medics or hospital-based nurses. There are community physios and OTs who can make quite a significant difference to people's lives by getting the hospital bed downstairs, thinking about adaptations in the home, thinking about anything that will conserve energy. There can be a role for just a short course of steroid for fatigue. I don't use steroids in people who are still on immunotherapy without permission from the oncologist. And I tend to find if you suspect there's quite an inflammatory component, that you get more benefit out of the steroids. So I'm often looking for cachexia, anorexia, quite a lot of background low-level nausea, sort of low-level tenderness in the abdomen. And those people seem to respond better to steroids. And I try to limit steroids to 2 weeks, because once people get a benefit of them, they often want to stay on them, but sort of 3, 4, 5 weeks down the line, their own body cortisol's dropping, they're getting less benefit, they might be getting more Cushingoid, they might be getting high blood sugars, and we start to run into longer problems. So short bursts of steroids often are more useful. Edema. So I do go to lymphedema clinic. I haven't done an awful lot to develop it, as I was introduced by, but edema of the extremities is one of those things, I think, again, where people feel a little bit helpless to know what to do. And in cancer, it's often still quite multifactorial, the reason for edema. There's often still venous hypertension, whether that's long-standing due to poor veins or venous hypertension due to abdominal disease. It's often relating to progressive immobility. It might be relating to background obesity. We know obesity is linked to leg edema due to poor lymphatic flow in the superficial lymphatics. It might be related to previous surgery, previous radiotherapy due to cancer treatment. Again, low albumin is going to make the edema worse. So what can you do when people have got leg edema? The easy bit is to get them a good going emollient. As soon as you start to see the skin is tight and starting to get a little bit dry or thickened, they need something that is normally used for eczema. So Dipro-base, Zero-base, Cetraben. Compression is something that's good if the patient can actually manage it. Cancer patients are often starting to struggle with getting anything tight on, so it will depend entirely on the resilience of the family. If it's below knee, they can get it from the GP. They can sometimes buy some runner socks. They basically need something that goes from toe to knee to give them a little bit of squeeze. But if it's above knee, which is what we often see with gynecology edema due to having the lymph nodes involved or the lymph nodes removed, then they might need above knee compression, in which case they won't get that apart from coming to lymphedema clinic. Patients who've got edema due to a DVT, European research says that after 5 days of anticoagulation, we can start to compress the edema in the affected limb. So that's especially helpful for people who've got very tender legs post-DVT. And you can even just start with Tubigrip and work up from there if that gives them a bit of support. Diuretics in edema, avoid them unless you're pretty convinced that the edema is due to organ failure. Because otherwise what you're doing is you're trying to basically cause somebody to become intravascularly deplete with your diuretics. So I would only use diuretics in leg edema if you've either got a very poor EGFR and you're getting the feeling that they're getting fluid overload. If you've got evidence of cirrhosis or liver mets and you need to use some spironolactone and furosemide to try and affect the aldosterone pathway and clear the fluid out that way, or if they've got known cardiac failure, and you could diagnose that with checking a BNP, which will tell you whether there's a bit of fluid overload on board. So a raised BNP is an indication for diuretics. Another complication, hydronephrosis, is quite Common in the advanced gynae cancers. So again, hydronephrosis is a really tricky one because there are risks versus benefits to treating it. If it can be managed with a ureteric stent, that tends to be the most comfortable thing for the patient. In palliative care, we tend to counsel patients that one nephrostomy tube is good enough. 2 nephrostomy tubes is a little bit of torture because the patients can't get comfy at night because they've got 2 tubes. They can't lie on their back, they can't lie on their front often because they've got tender pelvises. And so one is generally where we would say stop. I'd always be really honest with yourself, and why are we trying to improve the renal function? Have we got an end point? Are we trying to get them through to chemotherapy with an EGFR level that we've been targeting? Is it that they can't tolerate all their renally excreted medication and we're desperately trying to get them back onto a sensible opiate plan, or gabapentin or pregabalin for neuropathic pain, and actually getting those kidneys working would help? Or are we just delaying their death? And if we're delaying their death, is that what they want? So for some people, it's really clear that they are quite sure that every day counts, every week, every month matters. But actually, it's sometimes worth just asking people, because sometimes people know what's coming around the corner, and actually they would rather have less tubes, less intervention, less hospital treatment than maybe an extra month or so of life. If the hydronephrosis is painful, then actually it's potentially worth talking about the nephrostomy to relieve the pressure symptoms. It's worth being honest with people that this might impact on their sleep, and whatever side you choose is likely to be less able for them to sleep on. It's worth telling them that we're going to be wanting to exchange the tube 3 monthly, and that's going to require a visit to hospital. But even if it's just a half-a-day visit, there's the risk of infection and there's the risk of displaced tubes. So we tend to be careful about bringing up nephrostomy tubes and being explicit about what we're trying to achieve. Fistulas are always a little bit of a heart sink. I think they're really, really difficult things for patients to manage. They have enormous social implications for patients who often, I think, find that they become increasingly housebound once a fistula is present. If there are surgical options, I think we need to address those early and try and see what we can do as soon as possible before the patient starts to deteriorate or before that albumin starts to fall. I generally think there isn't much that we can do as doctors, but once again, getting the district nurses involved, making sure that they get the best pads, that they've been seen by the continence team, that they understand that there is empathy for them, but there is little we can do, and it's a really difficult set of problems, fistula management. Nutrition. So nutrition is important to address if the patient wants advice and the patient has got an appetite. I wouldn't tend to refer somebody based on purely an albumin. But I do think people are distressed when they start to notice the weight loss. So people will find the dietitian helpful if they want to think about increasing supplements or increasing oral intake. Be careful of those patients who aren't actually too bothered by the reduced appetite, but it's actually their family who are bothered. I think sometimes acknowledging that we can't force people to eat, and that feeding people does represent love, but sometimes we have to show our love in other ways than putting big plates of food in front of them. It's also worth just thinking about the very end of life and nutrition and hydration in the very last few days of life. So this is, again, GMC guidance that we think need to consider nutrition and hydration in the last days of life, but that hydration is not a goal of treatment for the dying patient. So there is no pressure on us to put IV fluids up on somebody who's no longer swallowing. If we can agree that, we think they're in their last days of life. But it is important to think about how they are going to get a little sip here and there if they've got a dry mouth and if that's what they are responding to. So we tend to sort of down titrate from cups to beakers, maybe from beakers to a straw, When they can no longer suck, we go down to a teaspoon or a small 5 ml syringe and let them suck on one of those little purple 5 ml syringes. You can use the artificial gels and saliva for mouth care. Make sure that they are still getting their teeth addressed. A little bit of toothbrush from an HCA or from a family member is really important. And keep reassuring families that this is okay, and that as the body starts to shut down, as the organs slow down, the body actually needs minimal fluid, and that there is some therapeutic value in dehydration in the dying, so that actually that reduced incontinence is important for some of our tissues as we're no longer able to hold on to the urine, so there's less volume of urine. There's less nausea and vomiting as we start to have less fluid in the system. There's less pulmonary secretions. And actually, it is a part of an analgesic effect. As we have less fluid on board, there's less pressure on the system. So it is a natural part of dying that the body becomes slightly dehydrated as we move towards the last hours of life. But it's also really important for dignity care that we provide people with ways of taking that occasional sip when they're awake, and we facilitate a way to have a sip so that we're not leaving just a beaker on the side when that person is too weak to even hold the beaker. And we empower the families to be able to have a little syringe in a cup by the side so that they can syringe a ml or two into the side of the mouth. And a little bit of a cough on a little bit of fluid is not necessarily a problem. So, but if they are coughing on fluid, I would generally say limit it to 1 or 2 mils and then just stop and watch. And don't do that too often, but just enough to wet the mouth from time to time. So, who supports you? So you are important too. So there's a lot of people out there who can all help us with our patient care, but they won't help you unless we're clear about where we are in the stage of management. So keep your community partners informed. So when you write that clinic letter or when the discharge summary is written, it's really important to not just give the information of what the recent scan is or the nitty-gritty of what actually happened in hospital, because if someone's going home to die, maybe what happened 2.5 weeks ago in a hospital bed isn't as important as actually, did the patient mention whether they wanted to come back into hospital? Have the family felt that they've got the resilience to look after them at home when they're dying? Has anyone written a respect form, and what does it say on it, and who's making sure that the patient knows that they've got a respect form? Listen for any cues about what the patient's wishes are. So when people say things like, I wish it was all over, it's worth clarifying that and say, oh, I've just heard you say you wish it was all over. Do you mean you wish you were at home, or do you mean you wish you died? What are you wishing? And actually enable people to pick up on those cues, document the cues, but get those cues into the letters, because the people who are going to look after that patient when they die at home will find that helpful. Don't worry if it goes on a discharge letter that the family see. It's important to maintain that dialogue with the family while they're in hospital. Keep the gynae-oncology nurse informed, because the gynae-oncology nurse will have good links with the community. They will have links with palliative care. And do make sure that those people with persistent symptom issues or complex psychosocial needs are also referred to palliative care. What we will do, but what's open to anybody, is we will often refer to Macmillan, our Macmillan colleagues, for benefit support, blue badge support, for more well people, travel insurance advice, general information. They have got the national website, so it's always easy to find your local service. We have a hub inside our hospital, which is really helpful. Our local hospice, which is called Treetops, are really, really supportive. They do not only family counselling, they'll also do day sits and night sits, and they will send out a car to give injectable drugs in the night, but they have to know about the patient, so someone has to do the referral to Treetops. So that for that referral to happen, you've got to tell someone you want it being done. So you either have to refer them to community palliative care, or just the referral to the district nurses, and then the district nurses will do the referral on to Treetops. All of our palliative care documentation that spans both hospital and community for the whole of Derbyshire, both Chesterfield and Derby hospitals and all of our community partners, all of that information is kept on a website called the End of Life Toolkit, and that's actually being adopted at the moment by Birmingham and Nottingham. So they were going to have their own End of Life Toolkits in the next year. And again, your nurses on the ward will know how to refer to district nurses. When people are in hospital, some hospitals use documentation called AMBER. I would just give a little flag for that. It's really helpful. It was introduced by Guy's and Thomas's, and it's an acknowledgement about uncertainty. But we know in our hospitals that about 65 to 70% of people that we are acknowledging as uncertain will die during that admission, and 100% usually are dying within 3 months of discharge. So it's another useful bit of hospital-based paperwork to trigger conversations. Fast track discharge. So what fast track is, you will hear fast track mentioned in hospital and community. So fast track isn't about getting somebody out of hospital quickly. That's not what it's about. It's a national scheme that enables you to get NHS funding for a care package without having to go through a whole load of protracted paperwork. So by the say-so of the lead clinician that somebody has got progressive advanced disease, and i.e. they are dying usually in weeks, the funding for that package is agreed within 48 hours. And then as soon as the care package is available, it can start. If you are fast tracking somebody, don't just think about the funding. What else does somebody with weeks to live need? They need the discharge summary, they need a respect form, they need subcutaneous medications in the house. So those are all things you need to think about when you talk about fast track discharge. So our service is a very broad service. We cover the wards, we cover the inpatient teams, we cover community teams, we run clinics, but do refer to us if you feel out of your depth, because that's when we try to pick up. And I mention these whenever I do this talk, two amazing books for anybody who is interested. One is Atul Gawande, which I would always recommend, and the other is Kath Mannix, who talks about case scenarios about people who are dying, and she does that in a very supportive way and helps us understand how we can better look after the dying, and it's very generic and useful. So Atul Gawande, I flag him up because he's a surgeon, and he was trying to understand how, as a surgeon, he could be useful to people dying in modern society. And so what he learned to ask, which is within the book, is 3 really helpful sentences. So he's learned to ask the main concerns and biggest fears, the most important goals, but also what trade-offs they're willing to make to achieve those goals. And I think those are very wise questions. So lastly, recognizing deterioration can be done using your clinical intuition and considering the facts in front of you. And managing end of life can be complex, but if you can start just by being honest with the patient and make decisions relative to an honest conversation, balancing prognosis and risk benefit. My third tip is, when you deliver bad news, just sit back for a second, let the patient think. They'll have a busy brain. And if they look emotional and distressed, just say, was that a shock? As an empathic statement, and then move on from there. And you will find that people's distress doesn't distress you quite as much yourself. Anyway, thank you.
Thanks so much. Yes, that was great. Thank you. I think, as you say, it's like the confidence to just take that first step and maybe instigate the initial measures. And so that's been really informative. Just putting it out to the delegates, if there are any questions from the audience, if you want to just raise your hand for Dr. Lewis. No, nobody. I'll ask a question. Have you much experience of using, you mentioned about fistulation, about octreotide and how effective that is, and in what sort of format you would use it?
We had a bit of a run in palliative care for using octreotide in bowel obstruction to try and dry up secretions. And what we tended to find is, I think it doesn't tend to add an awful lot, and then we found that PPIs did better. In fistulation, I think it's really, really hard, because to a degree you're needing to try and keep the feces soft to try and keep them coming through. So I would say it's worth a try. It's worth a try. And if you're getting a lot of very stinging sort of offensive sort of discharge that's causing the skin to get very upset, and you can reduce the volume a little bit, it might help a bit. I can't remember a case, Susie, where it's made so much difference that somebody's gone, that's brilliant. It would just be small gains. Yeah, and I can think of people where we've used it, but I can't tell you that meant we didn't have to keep going in.
Yeah. Okay. That's lovely, thanks. And I hope you can see all the really positive comments in the chat. Everybody really enjoyed your talk. So if there are no more questions, then I think if everybody's okay, just to take the break as planned before we start the final session. So we're due to restart at 3:25. So if everybody's okay to be back and ready to start on time at 3:25. Okay, thank you so much. See you then.